think about the patient, think about your experiences and then think about the evidence as well. And I think if we can all try and combine those three things, we can create the most optimal patient outcomes.
Welcome to Beyond the Wound, your source of leading voices for healing people. My name is Cassandra Huff, and you were just listening to Dr Michelle Kaminski, our guest for today's episode. Michelle is the Podiatry Research Lead at Monash Health and has over 13 years of clinical and research experience in the prevention and management of high-risk foot conditions. Dr Kaminski has led several large research projects within the public health and university sectors and is passionate about embedding research into clinical practice and providing mentoring to junior staff in the conduct of research. Michelle has published 15 peer-reviewed publications, presented at 16 state, national and international conferences, has received 5 conference awards and has obtained over $360,000 Australian dollars in the competitive research funding. Dr Kaminski's greatest research achievement is her involvement in the development of the Australian Guidelines for Diabetes-Related Foot Disease, where she was secretary and first author of the Prevention Guideline. Today I spoke with Dr Michelle Kaminski. Dr Kaminski is a researcher, a clinician and a mentor, and we talked about the importance of an evidence-based approach to care. We talked about the various levels of evidence and what to do as a busy clinician in order to keep up to date with the latest findings. We also discussed where a clinician might start if they're looking to contribute to the growing bank of evidence in diabetic foot disease. Thanks, Michelle. Welcome to the studio today. It's lovely to have you here.
Thank you for having me.
So let's jump straight in, Michelle. As a researcher, why do you think evidence is important in lower limb ulcers and specifically diabetic foot disease?
So as we all know, lower limb ulcers, as well as including diabetic foot disease, can potentially be devastating complications for patients. I've worked with a variety of different clinical cases in terms of lower limb wounds, but more specifically foot disease, as my background as I'm a podiatrist. And these complications have massive effects on the patient's quality of life, not only from a clinical perspective where patients can end up obviously with infections and amputations, multiple hospital admissions, but also their ability to be involved in activities of daily living, being able to engage with their families and from that social perspective as well. So we know from evidence that working in multidisciplinary teams as well as adhering to guideline-based care can actually reduce the burden of foot disease and also can be cost-effective as well. So it's kind of a win-win. We're getting better patient outcomes and it's costing us less. So looking at the evidence and why is it so important to follow is we can provide the best high-quality and safe care for our patients so that we can get the best outcomes, but also reducing that risk of harm as well. Ensuring that we're being consistent in our care, so it's unbiased, it's streamlined, it's integrated with not only the clinician's judgments and clinical experiences, but also considering the patient as well and their values, their cultural needs, their preferences as well. And I think by following evidence, this is going to essentially help and guide clinicians in terms of helping to make those clinical decisions and coming up with treatment plans that's patient-centred, and there's that shared decision-making, informed decision with the patient and as well as the clinician. And I think evidence is also really important for generating new skills and new knowledge in clinicians as well. So there's that professional development perspective as well.
Great. Thanks, Michelle. One of the things that I took away from that, you talked a little bit about consistency and consistency of care. And I think that's really important, especially for clinicians that may be novice clinicians or clinicians that don't have necessarily a background in research or even a background in the high-risk foot service, for example, where you've practiced previously. Can you just talk us a little bit through, that consistency and how that's important for these clinicians?
Yeah, I think going back to that is consistency of care means that it doesn't matter what clinician that you are, what discipline you fall under. So if you're, for example, working with people with foot disease, whether it's a podiatrist, an endocrinologist, an infectious disease doctor, a nurse, there's so many different health professionals involved in the care, vascular surgeons, of course. It's important that it doesn't matter what patient presents to us, we are following evidence to provide them with the highest quality interventions that we know work and that we know reduce the risk of harm. And I think that is the most important thing, that it doesn't matter what background you have, what where you're from, you're going to receive the best care possible based on evidence. So for me, that's what the consistency of care means.
Thanks, Michelle. You talk about generating evidence, and I guess my question around that is there is a hierarchy of evidence. There is evidence that sits at the top of that pyramid, like randomised control trials, and then we have case studies perhaps down the bottom of that pyramid. And I wonder, in diabetic foot disease, where do you see the most relevant research to be done?
So going back to what you were saying about that levels of evidence, obviously the most important thing, I guess, as a clinician to understand the evidence is to, first of all, come up with that clinical question of what is it that you're wanting to know. And the first point of call would be to have a look at that top of the tier of that level of evidence. So, and that would be systematic reviews, potentially with randomised control trials, as you mentioned, and potentially that sort of quantitative meta-analysis is going to give you essentially all the pooled data together of all those studies. So that would be the best port of call for clinicians to go to first. Systematic reviews will essentially very systematically appraise all of the literature. And then if you're wanting to look at a particular intervention, if you're not able to find that within a systematic review or perhaps within a national-based or an international guideline, which is what essentially systematic reviews inform those sorts of documents, the next port of call would be to have a look at different trials that are unbiased and essentially are really rigorous and have great methodology, so that you can have a look at the effects as well as the harms of an intervention and whether that's going to work for your patient's needs. And then the next, I guess, part of that is if you're wanting to look at more of whether, for example, a risk factor can influence an outcome, that's when we come down to cohort studies. So probably the most common types would be obviously a retrospective or a prospective cohort study. Prospective cohort studies are generally better quality because it can give you that sort of temporal association between the risk factor that you're looking at and the outcome, whereas retrospective is obviously it's already happened, it's occurred in the past, and a lot of it is looking back on medical records and things like that. So having a look at that different qualities of evidence, and I'd encourage all clinicians to sort of have that basic understanding of what to look for in different types of studies and the literature that you are looking at. And I think one of the other things that's really important for clinicians to consider when they are looking at the evidence is to think about, is your patient similar to that of what's been investigated in these studies? Does the treatment have a clinically relevant effect? And is that intervention going to give you that benefit and obviously outweigh the harm is the most important thing. And then weighing up the patient's values, the patient's preferences, and does that fit in with the intervention as well? Or is there an intervention that may suit the patient better when considering all those aspects as well? And I will say, while I am a researcher as well as a clinician, while it is optimal to obviously provide the best treatment for your patients based on evidence, this is not always possible. And there's lots of different reasons for that. It can be related to, obviously, the clinician's judgment, past experiences of what's worked and what hasn't worked. But I think if the clinician could be as informed as possible with what evidence is out there, then they can obviously work towards getting the best outcome for the patient and what intervention is going to work best for them.
Great. Thanks, Michelle. And I like that you've made that distinction between evidence-based practice, evidence-based medicine, should I say, and evidence-based practice, looking at the patient's cultural needs and, geographically where they live perhaps, and, in consultation with the patient, because ultimately at the end of the day, it's about the patient. I wonder, given your answer to that question, whether you have ever been in a situation where perhaps you've deviated from the evidence consciously and made a choice that is very different from what the evidence suggests. And when you did that, and what was the outcome?
That's a great question. And it is something that does happen, of course, within our clinical practice. Probably for me, the best example of this would be, and specifically related to my clinical experience in foot disease, is changes to offloading plans that may not necessarily fit with the recommendations, obviously in the guidelines. So to give you an example of this, looking at a plantar foot ulcer, we know from the evidence that the best way to offload that is with a non-removable knee-high offloading device. In some patients, this is just never going to work. So I always look at, are there any contraindications for that? That's the first port of call, obviously, before you're making that clinical decision. But in terms of then speaking to your patient about how is this going to affect their life? Because obviously being in a cast for such a long time, we're talking months, could really affect their quality of life. So I've got a few examples, I guess, of this that I can think of. That one is related to cultural needs of a patient who identified as an Aboriginal and Torres Strait Islander. He explained to me that a really important cultural need for him was to have that connection to the land. And so by being obviously confined to a total contact cast, as an example, this was just not going to fit with his lifestyle and the way that he wanted to go about the treatment. So modifying that to having still a knee-high offloading device, but having that removable aspect of it. So we've sort of gone to the next level of offloading. Mm-hmm. Another example is I've had patients who have really severe claustrophobia and just can't even fathom being in a cast. And then you've got things like patients who have specific working conditions. So it may be that if they're working a trade and they're on site and their employer doesn't allow them to wear a cast, but then they'll allow them to wear, for example, a cam walker or something like that. So looking at the patient as a whole is really the most important thing.
Often we as clinicians practice what's embedded within our local protocols, which may be not necessarily up to date. Mm-hmm. How would you as a mentor uncover alternative practices in a way that follows evidence-based practice if they're seeing these issues in their own clinical space?
So I think the first thing is to identify what is the issue within clinical practice. So is it that, for example, the health service is seeing, if we're talking foot disease, they're seeing a lot of recurrent ulcers coming back to the service? What might be some of the reasons for this? So first of all, asking that clinical question, what is happening? Then going back to, for example, guidelines or the literature and seeing, well, what are some interventions that we could potentially bring into practice that could potentially help with this issue? So investigating, literature searching, finding out the best interventions for that issue, and then looking at how does that fit into the health service. So is it going to fit in with So implementing this, is it going to fit in with the policies and procedures that that health service has, and adapting that to give the best outcome for the health service to actually implement it, making sure it's sustainable as well is really, really important. Different health services may have different patient demographics as well. So how is it going to work for that patient demographic as well, and how are you going to tailor that intervention? So I think that's probably the first port of call. And then once it is implemented, evaluating on how it's gone. So has there been a reduction in recurrence rates? Has there been a change in the patient's quality of life, for example? So there's lots of different health outcomes that you might be able to have a look at in terms of when you implement something. And it doesn't need to be a full randomised controlled trial or anything like that. It just needs to be something where you've identified an issue, you've researched the best way to fix it, essentially, and then implemented and evaluated on how that's gone, I would say would be the first sort of thing that I would do from that perspective. And I think if we're talking about if, for example, clinicians, if they're wanting to get involved in research or, sort of dabble in that sort of space, if they haven't had any experience before, I'd highly recommend finding a mentor.
I think you've opened yourself up there, Michelle, though. You might have become the mentor that people go to perhaps for the future. You might have a lot more work coming your way.
Yes.
But Michelle, I think that's great for clinicians that are interested in research, interested in becoming involved in research, that have the time and the inclination to do that. But not all clinicians, I suspect, are interested in researching themselves. How do these people remain current in their practice?
I feel that research should really be an essential component of all health professionals and in their practice. So whether that is that they're an evidence consumer, so meaning they have a role in understanding and translating that research and applying that research, or whether they are an active participant. So whether it's they're generating research or generating new findings and translating that into practice as well. So I think there's that research continuum of no experience to quite experienced in terms of that. So I think we all have a role in that to play. It's important that we understand new interventions that are coming about so that we can obviously provide the most optimal care for our patients. That's essentially what we're trying to do, linking back to the clinician's judgment and clinical experience and bringing that all together to provide that shared decision-making with clinical decisions and treatment plans. Some other strategies of not necessarily conducting research, but to be evidence-based in your practice is about seeking out professional development opportunities, developing those networks and partnerships, being aware of any sort of national or international guidelines can obviously help to guide you to make the best decision with your patients as well.
It seems like a recurrent theme, Michelle, that we're talking about receiving and sharing knowledge, and I think that's a really important theme to draw out of what we're talking about here today. So if we're thinking about sharing knowledge and research and knowing that there's a lot of work to be done and some exciting things ahead in the space of diabetic foot disease, where do you think your opportunities for research might lie in the future?
Yeah. So I think the thing that stands out most for me when you asked me that was what are essentially the research priorities? And recently, Diabetes Feet Australia, who is an amazing advocate for prevention as well as management of diabetes-related foot complications, and they've recently put out the top 10 priorities for research, where they addressed not only health professionals and their opinions on what the top priorities are, but also consumers as well, which I think is so important. And I think what was really interesting was in that space was one of the top priorities was to look at an economic evaluation of guideline-based care versus optimal care. And I think this is a great clinical question, because particularly in light of the new Australian guidelines, and obviously the International Working Group are also working on the 2023 version of the guidelines as well. So I think that is an amazing question to be asked, and it is something that I, as a researcher, have been involved with as well. So I'm currently working on a body of work looking at the burden of diabetes-related foot disease, which is really, really exciting. And it's really great that it is aligning, obviously, with the Australian top 10 priorities. I think it's really interesting as well that one of the other priorities for clinicians, so their top priority was to how do we improve outcomes in people who identify as Aboriginal and Torres Strait Islander, which I think is a fabulous clinical question. From my understanding and from my own review of the literature, there really isn't much there. So I think this is a really exciting new opportunity for us to look into as well.
Thanks, Michelle. And I think you're right. Prevention is the key. And, we hear experts talk around diabetic foot disease and diabetic foot ulcers being in remission rather than necessarily healed, and that the burden or the likelihood of reulceration is extremely high in these patients. So I think you're right. The prevention aspect of research is incredibly important. So well done in that space. Michelle, I have a question that we ask all of our guests at the end of the podcast, and that's around if you could tell the audience or give the audience one little bit of information as a takeaway from what we've talked about today, what do you think that would be?
Yeah, I think probably the biggest thing for me working as a clinician as well as a researcher is that it's the responsibility of all of us as health professionals to be research informed and to be involved in evidence-based practice and encouraging others. So whether it be junior staff that you work with or encourage